The next oral abstract is session 3, the third oral abstract presentation, and it will be moderated by Bertrand. Okay, Bertrand Audouin. He's the Vice President for Global Health Initiatives at the International Association of Providers of AIDS Care. Bertrand, the floor is yours.
Can you now? Oh yeah, okay, good. So I was just saying good morning, everyone. And it's my pleasure this morning to moderate this session, and we miss one, oh, you're coming. And with no delay, I will just introduce the first speaker, who's got a very French name, so I'm very happy, called Sylvia Rabionnet, even if she's from the University of Puerto Rico in the United States, and will present about perinatally HIV-infected young adults, welcome PrEP and envision its potential in curtailing the epidemic. Please.
Good morning to all. It is for me a great satisfaction that I stand here today with the responsibility, first, of giving voice to a group of perinatally infected young adults, and second, to present part of the results of a study conducted by one of our students, Georgina Silva, and a group of collaborators, including Dr. Carmen Zorrilla, who is in the audience, Dr. Febo, Dr. Bastida, and myself. I want to thank the organizers for the opportunity to present how perinatally infected young adults welcome PrEP and envision its potential in curtailing the epidemic. Success in prolonging the lives of children living with HIV through the use of retroviral therapy, ART, has transformed pediatric HIV and resulted in new challenges. As these children enter adulthood worldwide. As they live longer, healthier lives, a variety of issues emerge, including sustained stigma, fear of rejection, the challenges of engaging in sexual relationships, and concerns about reproductive rights and family procreation. There's a paucity in studies and low representation of this population in research efforts, especially ones aiming at capturing the voices from a life cycle perspective. The advent of PrEP and biomedical interventions offered them additional tools for prevention and sexual negotiations. The purpose of this study was to examine how perinatally infected youth experience the impact of HIV in their lives. This qualitative phenomenological study seeks to explore the experiences of being a youth living with HIV in Puerto Rico. In-depth interviews were conducted to a perinatally selected group of young adults from 18 to 30 years old who had knowledge of their HIV status and were willing to share their life experiences. A set of open-ended questions were used to guide the interview and explore personal, social, and medical matters. Questions were asked about medication meaning, intimate relationships, and acceptability of PrEP, among many. Today, I will be presenting the results regarding PrEP. 20 young adults participated in the study, all of them patients of a university-based pediatric unit. 8 were male and 12 female, 18 had completed high school, only 3 were married and were living in a permanent relationship. 10 were currently college students. As follows some results. When asked about their knowledge and opinion about PrEP, the participants tended to immediately approach the question. Sharing their stress about transmitting HIV, they reported feeling responsible for the well-being of their current or future partners. Most of them did not know what PrEP was. However, after a brief explanation, they were generally excited about the potential benefits. For example, Pedro, 19 years old, shared, "Good, it is a good method because it takes off the heavy burden. To us men and to any HIV infected or any positive. It takes away a big burden. You don't know how many times I have worried about that. In my girlfriend's case, I would like to give her, expose her to the medication. As I told you, it would take away a big burden." They felt greatly relieved to know that their partners could have a tool to prevent getting infected. They envisioned the multiple benefits associated to PrEP, including double protection, giving control to partners, and a way to curtail the epidemic. Fernanda, 21 years old, shared, "Magnificent. I hope it comes to light soon so that my husband can use it. How good would it be? It would be magnificent because maybe the transmission will stop. There's too much transmission, people know, but they still get infected." They wanted to know more about the side effects and efficacy. We should remember that these young adults are well versed on medication and its effects. Based on the advent of PrEP, some welcome the possibility of receiving additional education and counseling as couples. Again, in most cases, the young adults have been receiving psychosocial services all their lives. Marina, 23 years old, shared, I didn't know that at all. I didn't know that, but I know now, obviously. That's why I say get informed together, because I'm also old and I don't find out about new things. The voices captured can help to inform public health practices and transition to adulthood services aimed at this population in Puerto Rico and hopefully elsewhere. They urge us to consider the perinatal infected youth can benefit from PrEP and challenge us to fund and engage in further research in this area. The results also underscore the need for disseminating information about PrEP in a timely way. These young adults seem to welcome innovations and that will impact their intimacy and that will help them share the burden of transmission. Health services targeted to young adults should incorporate the latest information about PrEP. At this point, I would like to acknowledge the brave young men and women who trusted us and believe in the importance of these projects and shared their most intimate experience. The research team previously mentioned, including our research assistant, and of course the funding sources. Thank you very much.
I suggest we keep questions to the end of the session, maybe. And go to the next presenter, Samantha Westrop from Public Health England, who will be presenting about a comparison of clients using national online HIV self-sampling services with those testing for HIV in STI clinics in England. Please.
Thank you. I'd like to take the opportunity on behalf of myself and the co-authors to thank the organisers of the conference for inviting us to present this work. Firstly, I'd like to start by saying that HIV testing is a salient component of HIV prevention in England, and we have two most at-risk population groups, namely men who have sex with men and black African heterosexuals. These two national self-sampling services are represented here in a short schematic, just to explain to you how it all works. The client is invited to order a self-sampling kit online. The kit is then delivered to their postal address, where they can provide a self-sample, and that sample differed according to the services. So on the left we can see the HPE-THT service that took a dry blood spot sample, and on the right the Dean Street at-home service, which clients are invited to provide a choice of either oral fluid or 400 microlitres of blood. The client would then post back the sample to the lab for processing. In the event that there was no reactive result, clients would receive an SMS from the service informing them of that. In the event of a reactive result, clients received a phone call from the service and were referred into HIV care. So the aim of this study was to evaluate the effectiveness of two national self-sampling services for HIV testing and compare them to HIV testing in GU medical services. To do this, we looked at online orders made over a 5-month time period through the two national services, and they were analysed to determine the number of kits distributed, the proportion returned and the proportion reactive, and then the age, sexual orientation, ethnicity and geography of residence of the clients ordering these kits. This information was then compared to clinic attendees receiving an HIV test in GUM clinical services nationwide throughout 2013. So here's a quick table of the results. Of note is the top row, which shows results from both services and all populations that were targeted. 12,500 kits were distributed in a 5-month period, with a 53% return rate and a 1.4% reactivity rate. This equates to 92 newly diagnosed HIV-positive individuals. Although in the HPE-THT service we can see the return rate of men who have sex with men compared to black African heterosexuals, the black African heterosexuals' return rate was lower. However, the reactivity rate was substantially higher at 3.5%, which equates to 9 individuals in this case. So moving on to the age of clients, the most popular age of clients for all 3 services, so the 2 self-sampling services and the GUM clinical services, was this 25 to 44 age bracket here. And this graph, we have the return rate on the y-axis and the age group on the x. The HPE-THT service is shown in blue and the Dean Street service shown in red. And we can see that for both self-sampling services, return rate increased as the client's age increased. So the final set of results I'll present to you today is the geography of residence. We have 3 maps here of England, and we can see that for GUM clinical services, the darkest area is around London, and that represents 50% of GUM clinic users testing for HIV resident in London. And this is compared to 39% of the Dean Street users and only 18% of the HIV Prevention England THT service users. And as a result, as is shown by the more even spread of the red and orange colours, the 2 self-sampling services in the centre on the right-hand side show a much more evenly distributed, even distribution nationwide. So in conclusion, the 2 self-sampling services successfully recruited both men who have sex with men and black African heterosexuals specifically, with a distinct geographic distribution of clients than those attending GUM clinical services. The services diagnosed MSM in a comparable proportion and black African heterosexuals in a higher proportion than GUM clinical services. Self-sampling is a novel, effective and potentially cost-saving method of expanding HIV testing to individuals at high risk of infection who otherwise may not test in existing clinic-based settings. Self-sampling facilitates the required expansion of HIV testing that is necessary for HIV prevention in England. So finally, I'd like to thank my co-authors, my colleagues as listed here, and of course the service users. Thank you very much.
Thanks a lot, Samantha. Our next speaker this morning is Nadia Abou-Lezam from the Harvard School of Public Health in Boston, who will be presenting about can the HIV epidemic be eliminated in South Africa using combination prevention. Please.
Thank you. So I'm not going to provide any background information. I'm really going to jump into the methods. We know that South Africa has a large HIV burden. So the model I'm talking about is a CPAC dynamic model, or the CDM. It's a stochastic, individual-based model that simulates HIV transmission between male and female persons with high and low-risk sexual behavior. Individuals in the model can become HIV infected during sexual acts in each of 4 possibly concurrent partnership types: steady, regular, casual, and commercial sex worker partnerships. The force of infection in our model is dictated by viral load, circumcision status of the male partner, and condom usage. The CDM is paired with CPAC, a well-established cost-effectiveness model that details disease progression and the testing and treatment cascade. Once infected in the CDM, individuals progress through disease stages in CPAC and are able to receive testing and treatment. ART reduces the HIV viral load of infected individuals and subsequently decreases their ability to transmit in the CDM to their uninfected partners. The model is initiated with 100,000 individuals, and the HIV epidemic is initiated with 6 HIV cases among high-risk individuals after a 50-year stabilization period. The model has been previously calibrated to sexual behavior, incidence, and prevalence data in the pre-ART period. In this analysis, we examined changes to the default parameter values for testing, treatment, and primary prevention, here, condom usage and circumcision. And we do this individually and in combination to idealize values using 5 different scenarios. We define elimination as reduction of HIV incidence under 1 case per 100,000 person years, and we examine additional outcomes of HIV prevalence and infections averted. All scenarios are assumed to begin in 2013 and last 50 years until 2063. We examined 5 scenarios of interest, and the parameters for these are outlined here in the table. You can see that we have a bit of granularity in the testing and treatment cascade that we've previously discussed. In the realistic scenario, default or current parameter values are assumed to continue for the next 50 years. In the ideal scenario, all parameter values for testing, treatment, and primary prevention are idealized, and we realize these are unrealistic, but we want to see what the maximum possible effect of changing these parameters would be. In the ideal condom use scenario, condom use is perfected in all partnership types, but no other changes are made to the testing and treatment cascade. In the ideal circumcision scenario, all adult males are assumed to be circumcised immediately and subsequently in 2013, but no other changes are made. In our ideal testing and treatment scenario, all aspects of the testing and treatment cascade are idealized, but no changes are made to the primary prevention parameters. Jumping into our results, with annual incidence on the y-axis and time on the x-axis, we see that in the realistic case of continuing current levels of testing, treatment, and prevention interventions results in a relatively stable incidence curve over the next 50 years. In the ideal case, here in red, we are able to eliminate HIV on a 50-year time horizon, with the black arrow indicating the point of elimination. In the absence of idealized condom use and circumcision campaigns, but perfecting the testing and treatment cascade, we manage to reduce incidence dramatically, but are unable to achieve elimination. Idealized condom use also results in dramatic reductions to incidence, but does not lead to elimination on a 50-year time horizon. When looking at prevalence, we see that in all scenarios with dramatic reductions in incidence, prevalence decreases slowly, indicating that transmission reductions outweigh survival increases in these scenarios. And this was mentioned previously by Dr. Hayes this morning. Continuing at current levels of testing, treatment, and primary prevention interventions leads to an increase in prevalence, primarily due to increased survival due to the ART, but no decrease in transmission potential. We're able to avert nearly 280,000 infections in the ideal case compared to the realistic case. Here I'll note that we began with 100,000 individuals. And in the ideal circumcision case, we only avert 60,000 infections, the bulk of which occur immediately after 2013. This analysis is limited by the assumptions implicit in our model. Additionally, we do not take into account any behavior change due to testing, treatment, or primary prevention interventions, and we assume that sexual behavior and testing and treatment behavior are independent. We've shown that the timeline and potential for elimination is not as quick as previously calculated, and that elimination is only achieved when testing and treatment interventions are combined with primary behavioral interventions, like condom usage or circumcision. Optimistic assumptions on primary prevention and condom use are required to reach near zero incidence. Aggressive combination prevention programs that include primary prevention interventions provide the greatest chance for reduction of incidence and eventual elimination. I'm presenting on behalf of a large group of co-investigators. Thank you for your time.
Thank you. Our last speaker for this session is Virginia Schubert from Housing Works in the United States, presenting on the undetectables, using financial incentives to support viral load suppression in a community-based organization providing integrated care.
Thank you. Long title. And I actually have a handout if anyone's interested. I'll just put them here for now.
Okay.
So thank you for being open to hearing about a community-based demonstration project that sets out to determine the feasibility, effectiveness, and cost utility of financial incentives as one component in a community-based program that's designed to support ARV adherence among homeless and formerly homeless people living with HIV who receive integrated care, health, behavioral health, and social services, housing, harm reduction, needle exchange, etc. At Housing Works, a New York City community-based organization that grew out of the Housing Committee of ACT UP New York. So, So who are the undetectables? You see I'm wearing my pen, and I appreciated that shout out earlier to social media. The Undetectables campaign is an ARV adherence initiative with a goal of getting to at least 80% viral suppression among Housing Works members who are HIV positive. We launched the initiative just this past March with an Undetectables superhero marketing campaign, and I've brought you copies of the first in a series of comic books. The superhero marketing campaign is designed to promote viral suppression as a core principle of our community, to counter stigma, to encourage open discussion in the community among everyone about viral load as a sign of good health, and to promote peer-based ARV adherence support. So as you'll see if you check out the comic book, we have superheroes like the gender warrior and the harm reducer who are taking on familiar foes like apathy, stigma, and fear. So we launched with the marketing campaign. And so who's participating in the Undetectables campaign? As I said, Housing Works is an integrated care model with a strong commitment to service provision, advocacy, and building opportunity. For example, through a job training program that over 25 years has graduated 25% of our current 500 staff members. We founded Housing Works in 1990 to create low-threshold housing opportunities for homeless, positive New Yorkers who were at extreme risk of tuberculosis in city shelters. Now we're thrilled to be advocating for housing as health care and as a critical enabler of ARV treatment. Housing Works operates in a resource-rich setting in New York State where implementation of the U.S. Affordable Care Act has provided near universal access to insurance coverage for ARV treatment from the point of diagnosis. Given that context, our community includes many people with HIV who face multiple barriers to ARV adherence, including long-standing health disparities based on race and class, extreme poverty, housing and food insecurity, and extended histories of mental illness, chemical dependence, and incarceration, which sadly in the United States are tightly linked. The Undetectables project is a 24-month demonstration project funded by the Robin Hood Foundation, a private foundation. Eligible Housing Works members are those who are eligible for voluntary enrollment or those who receive primary care through a Housing Works clinic and receive at least one other care coordination service at the agency. Our goal is 80% viral suppression at the measure of 50 copies or below. We've already this year achieved our goal of 100 enrollees, and with an ultimate goal of enrolling 700 clients in the demonstration at the end of 24 months. The other important point here is that at Housing Works we felt that this project was a vital part of Housing Works' commitment to the recently announced New York State plan to end AIDS as an epidemic in the state by the year 2020. And that task force, I think, is being announced today to roll out a plan, because frankly, if we can't end AIDS as an epidemic and end it for every subpopulation in our resource-rich environment, then no one can do it. We developed, in collaboration with our academic partners at the University of Pennsylvania, an adherence toolkit that includes, well, it's a stepped approach that moves from a least intensive intervention, a $100 financial incentive for achieving viral suppression or maintaining viral suppression at each quarterly viral load testing point, and then moves through successively more intensive and more expensive interventions like cognitive behavioral therapy groups and medication reminders, pillboxing, and DOT. I'm not going to go too much into the evaluation design, but we're working with UPenn to evaluate. We're using a time series model primarily, and I'm not a researcher, so I'll tread softly here. But our research design will examine the acceptability, feasibility, effectiveness at achieving the goal, and cost utility, primarily as a function of savings realized through averted downstream infections. This is a very tentative look, don't hold us to this, at our first 6 months. Again, I said we started in March. Right now, for the 490 clients who are currently enrolled, we're at about 77% viral suppression at the 50 or below mark, about 20% detectable, and about 3% unknown, who either refused testing or testing was inconclusive. This is very, very tentative, but you can see, too, from the very early look at time series, we looked here at 363 clients, about 75% of enrolled, for whom we had in electronic medical records at least 2 time points prior to enrollment and at least 2 time points post-enrollment. And as you can see, we're seeing some encouraging differences in the number of folks suppressed at each time point, pre and post. Because in our group of folks, we have a pretty high rate of rebound after, from time to time after suppression is achieved. So back to our campaign, what does it mean to be undetectable in our community? And this is a really important part of the initiative, and I can tell you that clients are very excited about being part of the plan to end AIDS in their community, to end AIDS with them. So we're trying to flip the stigma on its head and make it very cool to be an undetectable. There you go. Thank you.
Thank you. Time 2 minutes for questions, please. Yes, please, there at the back.
A question for Samantha Westrop. I think sampling has an important role to play in testing, especially because it maintains the possibility to link people to care. Now, do you have more data about the users in particular? Did they attend a gum clinic previously? How often and when?
So we do have data. We have an analysis of a subsample of individuals, about 4,000 people who ordered self-sampling kits. As to the frequency, the date of their last HIV test. In the Black African heterosexual individuals, only about 12% of them had tested within the last year. In the MSM, that was about 25%. So currently, our Public Health England recommendations for MSM are to test more frequently than that, and also dependent on when you change sexual partners, and if you're having unprotected sex with new or casual partners, you should be testing quarterly. So we only have 25% of individuals using the service, men who have sex with men, that are testing within the last year. We also have information regarding the number of sexual partners that they reported and the number of unprotected sexual partners. That was presented at AIDS in Melbourne, so perhaps if we can either talk in the break or you could have a look at the oral abstracts in Melbourne as well.
One more question, please.
Thanks very much. My name is Kita Mburu, and I'm working with International HIV Alliance. My question is really to the last presenter, and I think it's great that we can see that we are responding to the need to make sure that people are suppressed virologically, and we're looking for durable suppression. And my question really goes to the presenter, because I think in terms of incentivizing people to stay on treatment and maintain viral suppression, I think this is a great initiative. And it is responding to well-known a lot of structural barriers really to adherence to treatment, one of which is, economic problems. So my question is twofold. First of all is, what do you think is going to be the kind of message that we need to give out, especially in relation to sustainability? Because in countries or situations where we work, which is low developing countries, questions of cost and cost sustainability may actually prevent us from implementing some of the incentivization ideas that we have. And I think there is a good reason now for us to start thinking about what is the cost of not having somebody being virally suppressed. Because if you have that cost, then you can be able to actually say giving $100 for somebody to remain virally suppressed is actually still effective. And the second point is really where you see the program going in terms of sustainability within your own setting. Thanks.
Absolutely, one of the things that we want to demonstrate through the project. Oh, sorry, now I'm on. Okay. Absolutely, one of the things that we'll be looking at through the project is sustainability and the potential for scale up. So we need to demonstrate that it's cost effective. And there is some research in the literature that would indicate that at a cost per person per year, like the projected cost of this program, in our setting, it would definitely be a cost-effective approach through prevented downstream expense. There also is, I'm not the expert, but there is a great deal of, and a growing body of research, and I know David Wilson is going to be here this afternoon, that shows cost-effectiveness and cost-benefit across sector for interventions like cash support for young women to help them remain in school. So I think we really do need to be looking at the social interventions and taking a close look at their cost and their effectiveness, and modeling the cost of doing nothing, or the cost of addressing the social drivers that we know are impeding, are increasing risk and vulnerability, and are also barriers to adherence, even in a setting where treatment is available.
Thank you. We run out of time, so I'll have to thank the presenters for their presentation this morning. And you got that we all got a gift from Housing Works, so please come and get it here, I guess. Thank you.